Awesome. Thanks, Christine. Nick, do you want to introduce yourself?
Yes, sorry, had to unmute. So, hi, I'm Nick. I'm one of the chief emergency medicine residents at Washington University and the medical education coordinator for Techies Without Borders.
Awesome. Thanks, Nick. And I'm Jess Pelletier. I am the African medical coordinator for Techies Without Borders, and we're really excited to have all of you here. As always, please put questions and comments in the chat. Dr. Nettle and I will respond to those comments and questions, and you can always chime in with questions out loud as well. We love participation. With that, I'll let Nick go ahead and get started.
To piggyback on what Jess said, we really see this as an opportunity for information exchange, not just us telling you information, but we love to hear how things work where you work, or how you guys do things potentially differently, because I think there's a lot of benefit from all of us sharing how we navigate the same process in different settings. All right. So for this month, we wanted to focus on mass casualty incidents, specifically the triage. And it was admittedly entirely a coincidence. We did not plan this, but for the United States, it's a big day that it's September 11th. And so it's ironically fitting, but today we'll be talking about triage. So with that, we kind of have a broad opening case, but what we want you to think about is as if you were on a busy shift in the emergency department, when all of a sudden you hear a lot of like cars honking outside, shouting and screaming. You go to see what's happening, you see security is getting overrun by a mass of people coming through the entryway. Many are covered in dirt, some appear severely injured, and all of them are rushing towards you. And we want to know what you would do next in this situation, especially because it's super institution dependent, right? Facility dependent. And with this prompt, I'd love to kind of know what your immediate next step would be is if you were working and you saw this happen. Feel free to chime in verbally or in the chat.
Direct them to an open area like a parking lot.
Okay, I like that thought. Tell me more about why you would put them in the parking lot.
You need them in an organized space, in a place in which you can organize them at least.
Good. I like your thought process there for sure. A lot of times you might get resistance because they're like, no, I'm trying to get in the hospital because that's where I see the care. But you did a good job of recognizing you need space to execute that care and to evaluate the situation. That's awesome. Does anybody else have thoughts on whether they would do the same thing, do something differently?
Hello everyone.
Hello.
Yeah, I do think that at that point, it basically points that there's a big problem somewhere. So you got to inform someone who is in charge and see how you can organize your team and maybe get more information to understand what's really going on. And if you have more security, maybe within the hospital, you can then bring them on board. And I think that's a good point to start from.
Yeah, I love that point as well, right? You need a team lead and you need a point of organization, right? And admittedly, especially in healthcare, a lot of times doctors are really bad at this because they'll get 5 people that try to assert themselves as team lead, and then you have like a bunch of little mini teams, and it's hard to actually execute a unified plan. I also like your thought on what other resources can I assemble, and this is part of the reason I like this question is it's super institution dependent. So one of the main hospitals I work at, there's a security checkpoint where you cannot physically get through the doors unless somebody unlocks the doors, and so like realistically, it'd be very hard for people to rush the hospital. Now, there might be a huge rush outside the hospital, or sometimes we'll basically get almost like mini mass casualty incidents right outside the hospital. Like I've seen, like we have security cameras outside, and I've literally seen like fights break out outside, or you'll get multiple drive-up gunshot wounds and things like that. So trying to recognize, if they're already past your security, how might that be different versus if I have an ability to have a checkpoint that we can moderate flow, that can also be a really helpful point. And so there's no correct answer here per se that applies to every setting, but I just want you to kind of get the juices flowing by having you think about what you might do. So our agenda for today is we're going to start by defining a mass casualty incident, or MCI is what you'll sometimes hear referred to as some basic principles of the MCI, but we're really going to focus on a couple triaging methods and then go through the cases, or some practice cases. The idea behind this is when it comes to the triaging itself, you want to have it be fairly simple and straightforward so it can be efficient and high throughput. You can do entire subspecialty like fellowships in EMS and disaster management. There's so many nuances to it, but today we're just going to focus primarily on the triaging aspect. So for definition of it, there's multiple ways you can define it, but one of the common ones that I hear and like is it's the idea that it's when the needs of your patients exceed your resources, right? So if you're in a certain really sparsely staffed setting, 2 patients can easily overwhelm your resources, right? Sometimes you require lots of doctors, lots of nurses, lots of technicians, all helping on the same patients. And sometimes you can have lots and lots of patients and accommodate it well, even when you're under-resourced. I remember one time I was teaching at in the media of the institution, but I was teaching in Africa, and the hospital was actually shut down on strike, and there was an MCI that happened, and 15 patients were brought to this hospital and 15 were brought to another one. And literally by the time I was made aware of this, and I was literally across the hall from the ER and walked into the ER, they had already triaged 15 patients, and they found 10 of which were not really that injured, but the bus had rolled over, so they had blood on them, but turns out it wasn't their blood, right? So they were actually totally fine. And so they had 10 patients there that required almost no attention. And so sometimes it doesn't necessarily overwhelm your resources, but the other patients might be the ones that take a lot. So some of the basic principles is the English word of triage, my understanding, is based on actually a derivation of a French word that means to sort. And the idea here is that, and I apologize, my French is not good, but I believe it's off of Triage, but it's typically done by assigning a color status to a patient, typically green, yellow, red, or black, in order to indicate how ill or injured or urgently they need treatment. The goal is to do the most good for the most amount of people, and the response for MCIs, it should be heavily based on an established and rehearsed structure, right? A plan that nobody knows is not a good plan. You can have the perfect plan, and if the people that are there that have to execute it don't know it, you're not going to be able to deliver on it very well. I'm curious, does anybody know what their institution's plan is if there was a mass casualty incident? So like, let's say a building collapsed and there was going to be 50 plus patients arriving. Does anybody know what their institution's plan would be? If they do, I'm really curious to hear kind of what that might look like. Feel free to throw it in the chat or to speak up. I'm going to try and catch up on the chat. And if I talk too fast, feel free to tell me to talk slower. I know I have a thick accent and I also talk fast. So one of the things I think is really interesting about this is, especially in emergency medicine, we often kind of think of ourselves as the people that are supposed to be the experts at this. But if you just, on your next shift, go ask your coworkers what you would do if 20 patients showed up all at once and 20 sick patients showed up at once. And we actually did this recently at my institution in one of our weekly conference days. They're like, who knows the mass casualty plan? Like, who activates it? And we're all like, I think the ER attending does. And they're like, no, the chief nursing officer does. Right. And the idea being that the ER attending might not know the resources that are available from a system-wide perspective. Whereas at our institution, the chief nursing officer has a much better frame of reference on how much we can mobilize, how fast. And so if you don't know your plan, it's really hard to enact it. The other big thing is that you want it rehearsed, right? You want to be able to practice it, because even just a couple repetitions of practicing it can really improve your fluency at it. and efficiency. And so that way you can deliver at a much higher level. The big thing that's really important to know is that this is really dependent on the resources you have available, right? What works for another place might not work for your place. And what might be phenomenal for your institution might not work at all at somebody else's. And so it really depends on the status of your institution. For example, ours, until it was updated recently, I forget how old it was, but it was I think it was massively outdated plan. And so it might have been great 10 years ago, but it might not work at your current institution at this time. And so kind of checking in on it and seeing, are the resources that this was based on consistent with the resources we have now? And the big thing is that it's dynamic, not static. And so one of the things we're going to touch on when we do our triaging is just kind of like when we talk about seeing safety or your primary assessment, right? You might have to reassess it. Things might change. And so recognizing that just because it was a certain way at one point doesn't mean it hasn't changed as we move forward. So typically when we get to the triaging of actually assessing patients, there's typically, depending on the system you use, there's over 20 systems out there that are published, but a lot of them kind of go on a color-based system to suggest acuity and treatment order. One of the first ones is green. These are people who are unlikely to deteriorate and are sometimes called walking wounded, especially based on some of the ways that we assess these. These are the patients that literally walk to the ER or walk to the treatment center. Yellow is delayed, where they might have serious injuries, but they're unlikely to deteriorate within a couple hours. So for example, if I had a broken arm or a broken tib fib, I have an injury for sure, especially with the broken leg, I might not be able to walk. But if I sat there for 3 hours, I would still likely be okay. The ones that often get a lot of attention, and not just on scene in the incident, but also when we talk about it, are the red and the black patients. The red are kind of seen as the highest priority. They're also termed immediate sometimes because they have a life threat. If they do not get emergent care within like an hour per se, they are at a high probability of not surviving or having severe morbidity related to it. The black tags oftentimes might actually be your sickest patients, but these are typically termed as like expectant, meaning expected to die or already dead. And so it's really important that we triage appropriately, because this is a good example of if you had somebody who is not breathing and had no pulse, and somebody starts thinking about CPR, right, cardiopulmonary resuscitation, and they're going to try and do all the things like we would normally in an emergency department, you might dedicate 5-10 people to that one patient and miss many red patients that you could potentially save. Whereas depending on the injuries that led to this patient's arrest, they might not be able to survive anyway. And so this is one of those really hard parts, is deciding when somebody's not going to be able to be resuscitated in the setting. The other big thing is that how these fit can sometimes depend on your setting and your resources, right? So at big centers, oftentimes we don't use black tags much because you have the resources to try and resuscitate patients. Whereas if you're at a place where you have 500 plus patients and you don't have blood products, you don't have surgeons or things like that, what might be survivable might be drastically different. And so a lot of times we'll do physical tagging when we see patients. And so there's a couple different ways you can do it. Common ones you might see are tags like you see on the left here. Can you see my mouse, my cursor?
Yes.
Perfect. So these tags on the left here, what you can actually do is you can, when I practice with these, we'll actually have these and we'll just take like a paper clip and fold it to the level that is appropriate, because somebody can also change levels. So they might initially be a yellow, but then they might become a red, or if they're a red, but then we're able to be stabilized, they might de-escalate to a yellow. But you might be able to see a little bit, there's actually like a little like string at the top here. And so that's so you can actually drape it around a patient's wrists or something. And so it stays with the patient. And that way somebody is physically tagged. And so you know that they've already been evaluated. So you don't have multiple people evaluating the same patient before somebody else has been evaluated. Sometimes you'll also see things like what you have on the right here, which is literally like a bag that gets strapped around a waist. And it's got like, sometimes it's tape, sometimes it's like a ribbon. And so you can like tie it around a wrist, a leg, a waist. and that will identify that patient as that level tagging. And the nice part about this is that you can have tons of this, right? You can send somebody out with this and they could go tag 50 patients. Whereas it might be harder to send somebody out with 50 plus, 100 plus tags. And quite frankly, these are ridiculously expensive. There's really advanced ones, like for example, this picture, you see barcodes on here. This is so you can actually like scan a patient and associate it with like a medical chart. And so literally, I think they cost like $20 US a pop, and depending on where you buy them from. Whereas this tape, and it's very cheap, and you can get it in low resource settings. And so depending on what your setting is, something might work much better for you than others. I'm curious, who do you think would be the best person to do the triaging? Feel free to speak up or put it in the chat. Catch up on the chat. Constance, thank you so much for chiming in. Those least likely to get distracted by clinical details. I think that's a really interesting point. I see dental officer. Joseph, can you expand on that? Why the dental officer? I love that thought. I see registered nurse, experienced person, nurse or doctor. Wonderful. And also, while more people are chiming in, I see a comment from Booba where he points out that there's now another color called blue. So I'm not super familiar with the use of the color blue for this. I think the key is some systems might use it, and the idea is, so you in the comments said it's somebody who might be involved in the accident but is not injured. In most triage systems I'm familiar with, those are typically labeled as green because the idea is that the greens don't really need attention initially, and you can sort it out later. And there's also an idea that they might not be aware of all their injuries yet, and so they might still benefit from evaluation. So for example, let's say there was a building that collapsed and that person was outside the building but not struck by, they didn't know, they're like, I'm fine, I wasn't in the building, I'm not injured, but that doesn't mean that they didn't get hit with a bunch of rubble and just not realize internal injuries or something like that, especially if they have like a loved one who is injured. So in the example on MRAP, they had some really interesting commentary and pieces based on the Beirut explosion. And so it can be remarkably impactful on a person from a perception perspective when their loved ones are injured. So it's almost kind of like a distracting injury by proxy. And so somebody might say that they're fine or that they're not hurt, but they're really worried about their child that they brought in, and they might not realize they're injured yet. This is something we see in law enforcement in the US. One of the practices that they've started to develop is after a shooting where there's police involved, once the scene is perceived as safe, they'll actually pat down the entire officer. So the officer might not think that they're hit, but they will pull them specifically out of the scene and have somebody pat them down to look for injuries, because there's so much adrenaline flowing that they might not have even realized that they've been injured. So I personally do not use the blue category, but it doesn't necessarily mean it's inappropriate. And some triage systems might appropriately use it, but I'm not as familiar with that yet. Oh, looks like Jess, you want to speak more on that?
Yeah, blue just means expectant. So expecting to die, but not dead yet. So it's a subcategory of black. Most triage systems just count expectant and already dead in the black category. So great question, Booba.
Got it. The other thing I think is important too, depending on what resources you have available, especially once things settle down, meaning metaphorically and physically the dust has settled a little bit, the black patients might still be able to get care once resources allow, but it might be more palliative care, right? It might be spiritual care. You might be calling in chaplains. You might be calling in resources for palliation, such as pain medicine and Ativan for anxiety or things like that. For example, like when somebody's on comfort care, that doesn't mean we stop caring for them. The care just looks different. So it's something to consider as well, especially once everything has started to settle, is you also need to reassess these patients because like I said earlier, it's dynamic. And so they might change status as well, especially depending on how resources have changed. All right. So to kind of circle back to who should do it, this is actually kind of a hotly debated thing. So some people posit that somebody from the quote unquote lower level of training should do the triaging. And the argument is they're less likely to get distracted by higher level medicine, for example, right? So, for example, like a neurosurgeon might not be a great triager, right? Like they might recognize something they might be able to do for this person with a head injury and get very focused on that, or want to do certain focused exams, but they might get distracted by that. And it's kind of the idea that the sickest patient is the one you haven't assessed yet. So some people posit that, for example, EMS is really good at triaging because they can be very, very good at algorithms and going, if this, then this, if this, then this, and proceeding to move on. Whereas a lot of times, the higher the level of training, the more distracted they get with in-depth assessments, possibilities, considering about what they could potentially be doing for something. And we'll kind of get into that a little bit later. I've also heard the opposite posited, and to say that a doctor can't do triage is to suggest that a doctor can't be trained at triage. And so I think the big thing is, it's not necessarily a specific training level that is the best for triage. It's asking yourself who can perform the task the best. And oftentimes I'm biased because I originally worked in EMS, but oftentimes I think EMS is one of the best ones, especially because, thanks, Jess, especially because I want to save some of the higher level training that's used to the in-hospital setting for the treatment team. Right? If the doctor that knows how the system works and where all the medicines are and how much blood you have at the blood bank is triaging, then they don't have that information on the treatment team. And so sometimes having the doctors not be involved in the initial triage might be beneficial. But again, it's very system dependent. And it also depends on where it happens too, right? If your impression of the triage is that they come rushing through the door, it's not necessarily that EMS has an opportunity to triage them outside the hospital. Sometimes you're working with what you already have inpatient or like in the hospital setting. All right. So in these mass casualty situations, oftentimes in the initial phase, treatment can vary quite drastically. The focus is on life-saving interventions. So this is typically things like tourniquets, antidotes. So for example, in terrorist attacks, there might be antidotes that are really relevant. Needle decompressions or finger thoracostomies, some posit are helpful. Opening airways, not necessarily intubating, but sometimes just repositioning an airway, and a couple of rescue breaths are sometimes seen as one of the important life-saving interventions. And the treatment is often delineated to certain treatment areas. So some places they'll have like a green zone. This was kind of mentioned earlier, like if you use the parking lot, right? If you only have 10 beds in your emergency department, but you have 30 patients, you might actually restructure to work out the parking lot where you have the space to actually execute that care. But so sometimes they'll have like a green zone, a yellow zone, a red zone, and a black zone. And then you can staff your team accordingly, right? So you might have some of the higher level providers near the red patients, whereas you might be able to set a technician, a paramedic, a nurse, and handle 20 green patients at once, whereas you might need a lot more for the red patients. Also, one thing to consider is multiple facilities. So who are some of the first patients to show up in the emergency department for mass casualty events? It's a bit of a guess. I'm thinking. Yeah, great point, Tracy. It's a lot of times it's the walking wounded, right? These are the people that are oftentimes healthy enough to actually mobilize, right? The person that's pinned under rubble and has a crush injury can't get to the emergency department fast enough. So sometimes that first wave of patients is actually going to be some of the lower priority. And so, especially if you're involved in medical direction, one of the things to consider is if a mass casualty event gets established, is recognizing what resources the surrounding facilities have because you might divert some of the initial patients to some of those facilities. And they might say, no, I'm here, I need care, but they're about to potentially get rapidly triaged very low on the priority list. And so they're able to get to a different institution. Sometimes they can actually get their level of care faster and also allow you to focus more on some of those sicker patients. And a lot of times you don't have that ability, right? I heard somebody attended a conference in Boston, and they were talking about the bombing at the Boston Marathon. And I'd heard that one of the receiving hospitals first heard about the bombing from a post on Twitter. And they were like, hey, have you heard about this? And then like shortly after that, patients started flooding the emergency department, right? Or in the Beirut blast, like patients started showing up right away. You felt the blast, but patients started showing up suddenly before you necessarily knew what was going on. So the two main systems we're going to talk about here today are the SALT system and the START triage system. SALT, which admittedly I'm biased, I like START a little bit better, but this one's really common, so we want to mention it to you as well. It stands for sort, assess, life-saving interventions, and transport. And it's nice that a lot of these triage systems, they have a workflow that's able to be drawn out. So it's easy to study, it's easy to reference. And the idea is you want it clearly delineated. You want the fewest subjective components involved. You want to really decrease the burden of decision-making. And especially when you're super stressed, especially like, for example, if you work where you live, right? So if you work in your community, you might be treating patients that you know, and it can be extremely hard to triage people that you know. And so the idea is to make this very discrete and delineated. This one starts by an initial sort, and which we'll go over in just a second, and then the actual assessment and initial treatments. So for the sorting aspect, they kind of talk about walking, waving, and still. So the walking patients, that's right, the walking wounded. This is the patient that can walk into your emergency department. They say that's the group that it gets assessed last. They are likely to be the least sick. The waving, right, they get assessed second because they're not as good as the walking, but they're still probably injured if they're not walking towards you. And the still are the ones you want to assess first, right? The people that are sick enough where they can't walk. And that's what they want you to triage first. They talk about first you can perform potential life-saving interventions if you identify them. Then you evaluate the breathing, and that's kind of your first decision point on your individual patient assessment, so to speak. And then it talks about obeying commands or making purposeful movements, assessing the peripheral pulse, assessing for respiratory distress, and control of major hemorrhage. And so we can kind of see this here. And the idea is that you should be able to walk down this, right? So you come up to the patient. Is there a major bleed that you can put a tourniquet on? Are they having snoring respirations and a head tilt chin lift resolves their breathing distress, right? Are they a candidate for a needle chest decompression or finger thoracotomy or an antidote? And then you assess, are they breathing? If they're not breathing, right there, you've assessed whether or not they can get a life-saving intervention and they're not breathing. They recommend triaging this as dead. If they are breathing, you then go down to those next couple of questions. And if they have all of those yes, they're not going to be red or a black tag. You ask yourself, do they have minimal injuries? If so, then green. If they have more than minimal injuries, then they're yellow or delayed. And that means their treatment can be delayed a little bit longer. If you have no to any of these questions, you ask yourself, are they likely to survive given the current resources? And if the answer is no, then they get black tagged or expectant. And if the answer is yes, then they get red tagged. And then again, these are the ones that need that most immediate treatment that you have a chance of saving, but if you don't act quick, they will likely pass away. Now, the things that I'm less excited about this triage system is I think it's got too many assessment points in order that prevent it from being efficient. So evaluate for indications of life-saving interventions, right? This is kind of ambiguous on what that evaluation looks like. If you tell me I need to evaluate to look for a life threat, I'm going to do a primary assessment. And, that might involve rolling a patient to assess the back. And there's are you going to include, it can get kind of gray. I won't go too far down the rabbit hole. But again, it's me asking an open-ended question. What life threats am I evaluating for that I have a life-saving intervention for? It also says if it's a child, you can consider 2 rescue breaths. Again, that's an additional decision point to make. I have to consider whether or not to do it. It doesn't say give 2 rescue breaths empirically or don't give rescue breaths. I have to kind of decide. And then it's like, well, this kid's really young, I really don't want to give up on it yet, so I'll consider it. Or, hey, I don't think this one's going to do well, so I think I'll pass, right? I don't want that decision point if I can avoid it. And then there's a point where it says determine if they're following commands or making purposeful movement. Determining if they're following commands and making purposeful movements can be a super nuanced question, right? Like we run into this when we try to evaluate for seizures or functional neurologic disorders, right? So again, that can be a extensive consideration for some people. Then it's like, evaluate for respiratory distress. Well, what counts as respiratory distress? If they're coughing because there's dust in the air, is that respiratory distress? Or is respiratory distress like not moving air, snoring respirations? Do intercostal retractions count as respiratory distress? If it's a baby, does belly breathing, is that your threshold for respiratory distress? And so is crying and screaming and gasping because they're sobbing and screaming, is that respiratory distress? And so it puts you in a gray area. It says, are there minor injuries? It's like, okay, what counts as minor? Is a humerus fracture minor? Is a shoulder fracture minor, or a clavicle fracture? Because what if the clavicle injured something in the chest, right? It's a little less delineated. And likely to survive considering current resources, right? That's asking my triage person to say, okay, here's my assessment of this patient. Here's my knowledge of the resources of this system. Now I have to consider, I'm already making considerations on whether or not the resources fit this patient. And so that's a lot of decision making. And, going, okay, well, this person might need blood. Well, I don't know how much blood we have. So, is this candidate going to be worth using all of our blood? And you have a lot of decision making points there, which makes me a little less excited about the system. But so once you get through that first initial triage phase is when we kind of go back through this. And so now we've kind of mentioned some of those things, and I'm kind of hoping you can see where there's some of that ambiguity or where reasonable people can disagree, right? And the idea is in triage, you want it to be quick and you don't want anybody to waffle and try and decide, is it this or is it that? And disagreeing takes time. And so that's part of why I like the START triage system. It stands for simple triage and rapid treatment. The nice part is it takes an ABCD approach, which is very similar to how we evaluate a lot of our patients, especially trauma patients. And so it's less of learning a new thing and more applying what we already know in a different way. And so here's what that graphic looks like. And so I love how crisp and clear this is, how little ambiguity there is. Are they able to walk? If yes, they're green and they can get triaged again later. If they can't walk, I ask myself, are they breathing spontaneously? If they aren't, I can reposition that airway. And if they start breathing spontaneously, great, they're a red tag, done. If they're not spontaneously breathing after positioning that airway, black tag, done with that patient, moving on to the next one. If they are spontaneously breathing, I evaluate the respiratory rate. Is it over 30? Again, discrete number. It's either over 30 or not over 30. If it's over 30, that's a life threat to breathing, right? So first one's life threat to airway, second one's life threat to breathing. They get evaluated as a red. I'm moving on to the next patient. If the respiratory rate's under 30, I ask myself, are they perfusion, right? This is my circulation assessment. I'm looking for a radial pulse. They have a radial pulse. If the radial pulse is absent, they're classified as an immediate. If the radial pulse is not or is present, then I move down here. And the idea is not cardiac arrest versus not cardiac arrest. The idea is, are they able to perfuse the entirety of their body is kind of the idea with this. If the radial pulse is present, then I move down to here. If their mental status is good, they're a yellow, right? So they weren't able to walk, so they're not green, but I don't have a life threat to airway, breathing, circulation, or mental status. If they don't follow commands, right, you can say hold up 2 fingers or something simple. If they don't follow commands, then they're red because they have an abnormality with their disability in their primary exam. And so then what it talks about is once they're triaged, you can consider, are there life-saving interventions here? Where is it? Victim can be helped. Oops, can't highlight with this. Victim can be helped by immediate intervention and transport, right? And so I like this because it's very discreet and you're not wondering what category somebody fits into. There's also the jumpstart approach, which is, this is recognizing that it's a little bit different for pediatric patients in that we can't necessarily apply what we do for adults to kids. They're not always just little adults, even though sometimes there's a lot of overlap. And so this is the jumpstart one. And again, it's very discrete boxes, right? Is the kid able to walk? Yes, they're green, secondary triage. Are they breathing spontaneously? No. Then I'm going to try and reposition their airway, right? Kids have big tongues, right? You know, if I reposition their airway and they start breathing again, red tag, right? I had a threat, it was addressed, but still need to keep a close eye on them. If I reposition it and they're still not breathing, I want to see if they have a pulse. If they don't have a pulse, they're dead, right? No pulse, no breathing. The resources are likely not going to be beneficial here. If they have a pulse, try 5 rescue breaths, because for kids, the airway of breathing can be so big. Sometimes you can see big turnaround with a couple of rescue breaths, but if they're not breathing and they don't start breathing after rescue breaths, they're going to be expectant. So if they are spontaneously breathing, you want to know if the respiratory rate is really slow or really fast, right? Is it under 15 or over 45? If it is, that's a threat to breathing, immediate. If it's within a roughly normal range, or a not extreme range, if you will, ask yourself, do they have a pulse? If they have no pulse, but they are breathing, right? Then they're going to be immediate because they have a threat to circulation. If they are breathing, they have a pulse, you assess their neurostatus, right? So we went A, B, C, D. We'll do the AVPU scale here. This is alert, response to verbal stimuli, response to painful stimuli, or unresponsive. If you notice posturing, so your decerebrate or decorticate posturing are not responding, they're calling that immediate. And then this, it is a little bit kind of confusing here where it says appropriate P. What they mean by that is they kind of say it, I think at the bottom here, maybe not. But they respond to painful stimuli, what they call appropriately, right? Do they withdraw from pain, or do they try and push away from the pain rather than like a posturing perspective? And so this is basically saying if I don't have a life threat in ABC or effectively D, then they'll be yellow. And so I like this one because it fits, again, more discrete categories. And if there's any questions, I'm happy to take them, but I have a bunch of practice cases here that we can work on. I'll give a second here and try and catch up on the chat. With the head tilt chin lift versus jaw thrust, one of the debates is it depends on the mechanism too, but the kicker with the jaw thrust is it has to be maintained. And so if you have somebody that can hold the jaw thrust, especially like a bystander, and you say hold this, that can be super helpful, but also recognize what might happen if you walk away. All right, cool. So we'll go through some practice cases here. So feel free to speak out loud or chime in the chat. The idea is that these are going to be quick, because when you are triaging, you want to spend under a minute, 30 seconds on these patients to try and really be maximally efficient. Especially because if you have 100 patients and the sickest one might be the one you haven't seen yet and has a simple life-saving intervention like a tourniquet, spending too much time on that green patient might prevent you from saving that life. So first case, 20-year-old female walked into the emergency department screaming. We effectively already have enough information to tag this patient. What are we going to label her? And try and find my chat again here. Green, yeah, perfect. And one of the interesting things about this, while I'm not a huge fan of the SALT triage system, I recognize some people might, and it might work for your system. But one of the convenient parts is a lot of times these will be 2 different ways to get to the same answer, right? So if we look at either of these triage systems, right, this patient, if they are walking in and screaming, they're going to be tagged as green, right? They're likely, I mean, first, the SALT triage, they're going to be assessed third, but they're going to have minor injuries. They're going to be breathing because they're screaming. And if you can tell them to walk over here and sit down, they're likely perfusing well enough that they have a peripheral pulse, and they're screaming, so their airway is open, and they can be a minimal assessment. Sorry. That's not one. And then on the, sorry, I'm just moving things are on my screen. On the start triage system, they're walking in, they're green, you're done. All right. So second case, 60-year-old male is carried into the emergency department, not moving and not breathing, even after manually opening the airway. What are we going to tag this person? Okay, so I'm seeing blacks. All right, so if we go down our system here, so this person's going to get assessed first, right? Because they're still on salt. And so we would look to see if they have any major hemorrhage. We would try to open the airway. We said not breathing even after opening the airway. Let's assume that they don't have like, massive hemorrhage coming from somewhere, or that it's like a terrorism attack with like bioterrorism agents. But so not breathing, dead, done, is how they see that one. And then on this system, not breathing, not spontaneously breathing, reposition airway, still not breathing, black. Done. Right. So that was quick, right? Like, and one of the hard parts, and they really talked about this quite well in the piece on the Beirut blast, is the decision here from a medical perspective might be fairly easy. But that might be the easiest part of all of this, because the family might be screaming at you. The family might be saying, save my child or save my father. This might be somebody you know, or this might be somebody that you might normally try to resuscitate. And you have to move on to see if there's somebody else that you can save. So case 3, 44-year-old male is carried to the emergency department screaming that his leg hurts. It appears to be visibly deformed. What is this patient most likely? Let's say the respiratory rate is 18, just because Bernard asked what the respiratory rate was. And for clarity, let's say it's the lower leg, so like the shin. I'm seeing reds and yellows. So I'll move forward here. So we'll use both of these systems here. So they were carried in, so they'd be assessed second. Let's say we're not seeing any potential life-saving interventions that could be indicated here. No major hemorrhage, their airway's open because they're screaming. We don't think they need a needle decompression or an auto injector. Breathing, yes. Let's say follows commands, has a peripheral pulse like a radial pulse, non-respiratory stress and no major hemorrhage. So we'll say yes there. Minor injuries, broken leg. I'd call that an injury that needs assessment. So I would personally classify this person as red. Yellow, sorry. Now, if they had, let's say they didn't have a peripheral pulse, right? Then, and to be fair, I didn't provide that information, but if they didn't have a peripheral pulse, then we could end up in red, right? Or if it was an open fracture with serious hemorrhage, then they could end up in red. If we look at the start triage system, able to walk, no. Spontaneously breathing, yes. Respiratory rate, not over 30. Perfusion, let's say, has radial pulse. And mental status, following commands, we'll say, is delayed. I'll give you pertinent positives. So like, if like, you don't have to assume that they're squirting blood or that like they can't talk. I'll tell you. But yeah. So again, we can kind of end up in similar categories here. So case 4, 78-year-old male brought in by family, not initially breathing, but starts breathing after the airway is opened. And just for time's sake, we'll kind of click through here. So brought in by family, not initially breathing, but adjusted the airway, right? So there's a life-saving intervention. So not dead yet. And then let's say not following commands, right? Started breathing, but we didn't hear wake up. We didn't hear sat up or anything like that. And so this person could be a red if they started spontaneously breathing. And then on this system, not walking, so go down here, spontaneously breathing, no. Positioned airway, spontaneously breathing, red. And then I'm going to click ahead here just to get to a PEDS case. So you have a 7-year-old female brought into the emergency department by family. They're breathing at 50 times per minute. What tag would we give this person? So this will go to the Jumpstart triage system. Okay, I'm seeing a red. So in this patient, able to walk, we'll say no because they were brought in by family. Spontaneously breathing, yes. Respiratory rate, over 45, red. Done. So good work. And the idea with this too is, one thing I think it's underestimated in medicine is that every test has a sensitivity and a specificity. It has a wide range of test characteristics. Some of these might be mistriaged. So some people might say like, oh, well, yeah, but if they didn't have a pulse, we didn't get to pulse. If they didn't have a pulse, would I say that this person is not going to be likely survivable with the resources I have, depending on where I am or how many patients I have or how much staff I have? So recognize that this isn't a perfect system, but it is a system. And so recognize that whatever system you choose, make sure you discuss it with your team, you practice it. A great way to do this is you can take like a bunch of index cards or note cards and write sample patients on it like this, and just literally like throw them in a room, like just scatter them around a room, and then have somebody go in and practice triage. So they walk in, pick up a card, decide what it is, set it down, pick up another card, decide what it is, set it down. And so it gets you practice and repetitions going through each of these steps in order to really refine the skill and make sure it doesn't fatigue, because it's something we don't often use very often, but when you need it, you really need it. And it's a fun game. And so you can do it with your co-residents, your co-attendings, the nurses, the paramedics, whoever you might be with. And then okay. So to summarize, a mass casualty incident is effectively any incident where your patient's needs outstrip your resources. Triaging is going to be one of the most important things that you can do here, because that's how you do your scene size up. That's how you evaluate what's going on and how many critical patients you have. And then you can consider life-saving interventions, but make sure you have a system that is established, understood by the whole team, and is practiced, because we don't rise to the level of our like learning. We kind of fall to the level of our training, right? Amateurs go until they get it right. Professionals go until they don't get it wrong. So this is something you really want to make sure you're practicing a lot to make sure that when you need it, the skill set's there. And then with that, Jess pointed out that one of our participants is going to share about a recent case that they had that involved an MCI. I also
Thanks so
apologize
much,
while they
Nick.
share that. I'm going to have to step up because I got to start a shift. So Jess is going to finish out here.
Thanks, Nick. We really appreciate you. I'm going to turn it over to Dr. Joseph Emuran and his team, who recently had a mass casualty incident. And I would love to hear your experience and what happened.
Yes, thank you very much, Dr. Jess. I'm gonna give my colleague to take us through that. What we had here. I wonder whether we can share a short presentation, just like about 4 slides.
Screen sharing is enabled, Joseph, so you guys should be able to share your screen.
Okay, thank you. Okay. Yeah.
Hello, good evening. It's evening here, but greetings to all of you. We at Katakwi General Hospital, Eastern Uganda, we've so far had 2 major mass casualty incidents. The first one was in December 2023. This one involved about 40 people. 40 people who were involved in it hit a cyclist and eventually overturned. As you can see, it had both people and luggage. And then the second one was just this weekend, on 7th of September. Even it was at the exact same spot. Even here, around 74 people in this truck with luggage as well. So our observations, they're both similar. It's at the same location and a similar situation, ferrying a lot of people and luggage. We got the information quite early and we rushed there in about 10 minutes, 5 minutes. The information came through our emergency medical services. It was a bit incomplete. We just knew there was a truck that had overturned and there were many people who were injured. One person assumed leadership immediately and we divided. Some people went to the site and other people stayed at the hospital to organize and prepare because we don't have a functional emergency unit at the moment. So we created some room with the OPD and the patient shed where we usually have CMEs. We also mobilized the EMS, the team from neighboring districts. The neighboring district, they sent also some ambulances to help us. The scene had a lot of people, of course. Bystanders were the first. They were actually quite helpful. When we arrived, we didn't have a triage protocol, honestly. We triaged based on observation. Immediately we arrived, some people already pointed out people who are excessively bleeding and those who are unconscious. That's where we started. And then we went around checking one by one, asking the ones who could talk. We obviously mentally qualified that as yellow, but we had no tags. The police was around to help us with the crowds. We had teamwork from everybody in the hospital, from the team, from the quarters, and came in to join. Our plan is now, we want, according to what we've learned at this CME, we are planning to have our protocols to allocate resources because it caught us unaware and unprepared with very limited resources. So we had to refer a lot of patients after we stabilized them. We are organizing protocols and mock drills and CMEs to build for next time so that we are more prepared. I think that's mostly it, unless Dr. Joseph has more to add.
Thank you very much. Yeah, I think she's shared a lot of what we've gone through. What I can add in, usually this thing, they brings in a lot of teamwork at the hospital, but also at the community level. But really having a structured way and having like the tools to help us go through that, and then the leadership, the communication part of it. So these are things which we think can actually make us like improve this, as the previous presenter alluded. So you need to have some sort of drills, mock drills, and be able to simulate these situations. And for us, we've really noted in a similar area, most of our mass casualty incidents are really related to vehicles, which are open, carrying a lot of people because they are markets. Whenever there are mass gathering events, like maybe a women's conference or a prayer, they usually come in those trucks, and some of these trucks are in a bad mechanical state and they can easily crash. Yeah, and then I think the other one is things related to security. We have some training schools around, but also we have some cattle rustlers. So sometimes they can attack a certain place, and we may get many patients at the same time. Yeah, so that was our story. Thank you.
This was excellent. Thank you guys for sharing your experience. And I think it really emphasizes the importance of having a designated protocol, whether you decide to use SALT or START or another local protocol, emphasizes the point of great communication, and doing drills can be so helpful. And I want to thank everyone very much for attending today and for the engagement in the chat. This was one of our most engaged sessions. We appreciate your feedback, so please fill out the survey and I'll send the link again in WhatsApp to your individual groups. And if you are interested in helping to pick the topics for Journal Club, we do have a Journal Club board. Feel free to message me in WhatsApp and I can add you to that chat, or you can join from the CMES community on WhatsApp. And every month, those people vote on the topic, the date, and the time. Thanks again, guys, and I'll look forward to seeing you next month.
And then forgot to talk about the numbers.
Yeah, it's okay.